Hello, I'm Doug Wood, the Chair of Surgery at the University of Washington in Seattle, and today we've assembled a terrific panel of experts talking about the current advances in lung cancer early detection and therapy. As most of you know, lung cancer continues to be a huge health problem in the United States and beyond. It's really the second highest cause of death and the highest cause of cancer death in both men and women. And in spite of many advances, it continues to be a large cause of morbidity and mortality in the United States. But fortunately, we've made some major changes in the past few years in both early detection and in treatment for advanced disease. And so we're going to be talking a little bit about those areas today and looking at how these transformations in care for lung cancer patients can convert more of our patients to lung cancer survivors. So I'm going to ask each of our panelists to introduce themselves, beginning with Dr. Blackmon.
My name is Shanda Blackmon, and I'm a cardiothoracic surgeon at Mayo Clinic in Rochester, Minnesota. I practice general thoracic surgery, and I'm also president of Women in Thoracic Surgery.
My name is Lisa Brown, and I'm a general thoracic surgeon at UC Davis in Sacramento, California.
Mitch Magee, general thoracic surgeon in Dallas, Texas.
So it's great to have all of you here this morning, and I'm going to start with you, Dr. Blackmon. The National Lung Screening Trial certainly established a mortality benefit of low-dose CT for patients at high risk of lung cancer. And yet, it's taken a while to get implementation of lung cancer screening. Is there any new data about lung cancer screening and what's going on in other countries?
Interesting you should ask. The Nelson trial is one of the second largest lung cancer screening trials ever to be conducted. And we were all very excited when we saw the results of the Nelson trial because it also showed a benefit, not surprising, of lung cancer screening. The Nelson trial actually showed a huge benefit with gender differences. So if you look at the different data, there was a 61% reduction in women over a 10-year period with the Nelson trial in lung cancer mortality, compared to a 26% reduction in mortality among men. So now we're starting to see a little bit more granular detail, the differences with mortality reduction, and an even greater impact on women with lung cancer screening. Another interesting finding from the Nelson trial was that we noticed that the earlier lung cancers were detected. About 70% of the patients from the Nelson trial were picked up with stage 1 or 2 lung cancer during that time period in the treatment arm, and the treatment arm was low-dose CT. However, in the control arm, where we weren't picking up the early lung cancer with lung cancer screening, most of the lung cancer that was detected, I think about 70%, was stage 3 or stage 4. And we all know that when you get diagnosed with stage 3 or stage 4, the outcomes aren't near as good, and curative therapy doesn't really go into the sentence as when you get diagnosed with 1 or 2. So the Nelson trial is really a bit of a game changer. There might have been some people doubting what we were going to see with the NLST, which I can't figure out why, but it's just another big piece of evidence from a randomized controlled trial, large study from Europe that shows us exactly what we thought we would see. And since lung cancer is the greatest cancer killer, killing more people than breast, colon, prostate combined, it's nice to know that we have a tool to fight this tumor with.
So let me get this straight. So the National Lung Screening Trial showed a 20% survival benefit, and the Nelson trial showed 25% mortality benefit in men, but over 60% survival benefit in women.
Correct.
So that trial has shown an even bigger impact than that in the NLST.
Exactly.
What about false positives and the harms of lung cancer screening? Did the Nelson trial advance anything from the NLST in that regard?
Well, I think it's really important to look at the way that we assess those tumors. And the Nelson trial was very careful in the way that they managed these lung cancer tumors. They saw suspicious nodules, and they used very smart technology to decide how they would manage those nodules. And the rate of non-therapeutic thoracotomy was low. So I think what we can say is you can safely do low-dose CT screening, and you can effectively make sure that you're not over-intervening or over-diagnosing patients or even biopsying. Now, if a tumor is followed with very careful guidelines, and sometimes now we can even use radionomic data to look at how we follow those guidelines and look at how we interpret those nodules and carefully follow them over time and only intervene on those that are predicted to be an invasive lung cancer, thereby alleviating the concerns of our patients, not alarming patients too much, but at the same time knowing when we do need to intervene.
That's terrific, thank you. Dr. Magee, I'm going to turn to you. So this is great news. How well is lung cancer screening being adopted in the United States? And can you give us a sense of how many people are eligible to be screened? And then of those eligible, how many are being screened?
Well, it's nice to see data from Europe corroborating what we already have been trying to apply in the United States. We are definitely doing some better, but not nearly as well as we need to be doing. There are about 7 to 9 million people that are eligible to be screened now based on prior or current smoking history. But unfortunately, only about 2 to 4% of those patients are actually getting screened. It's nice to see that the number of eligible patients is going down from 9 to 7. And I think that is a reflection of our efforts both in policy to decrease the incidence of smoking, and the number of smokers eligible are going down, which is great to hear. But I think we still have a long ways to go to increase the number of patients that are being screened. It's important to remember that we're still very early in this process. Remember the data that we're looking at in terms of the number of patients that are eligible that are being screened is only a year or two old compared to the length of time that we've been able to provide CMS and other insurance coverage. So we're still very early in this process, and we still have a long ways to go to improve access. Access is still a big issue. I think there's still a big gap in knowledge in terms of educating patients that the benefits are there. If you look at it compared to breast cancer and colon cancer, for instance, which has a much lower mortality, cancer-related mortality, but has had very effective screening. Comparatively, lung cancer screening is much more effective than either colonoscopy or mammography. You have to screen over 1,000 patients to save a life when it comes to colon cancer, and similarly for breast cancer. But for lung cancer, you only have to screen 320 patients to save a life.
Let me follow up on that. I'm picking up on your point about a small percentage of patients right now are getting lung cancer screening. I know that some of the lay press has taken a position that this means people don't want to be screened. Are people voting with their feet? Is the low rate of lung cancer screening because they don't believe in it, or they just don't want to be screened for lung cancer?
I don't think so. I think it's still a lack of education. I think there's still a great opportunity for us to get the word out about the relative risks, that the benefits are so much greater than the risk. I think there's been mandated overemphasis on the risks and consequently underemphasis on the benefits, both in terms of educating the smokers and the general patient population, but also educating primary care physicians and other care delivery docs.
So, Dr. Brown, what are the challenges when it comes to establishing a lung cancer screening program? So we have a new preventive health care benefit, and we don't have enough patients having access that Dr. Magee just identified. What are the barriers to getting a lung cancer screening program going, and what are the things that you can advise people that want to develop a lung cancer screening program?
That's a great question. I'm the clinical director of the lung cancer screening program at UC Davis. And our program began in 2014, and when I showed up about a year later, I was placed in charge of that program, and at that time we were screening very few patients. And so I've really gone through these challenges myself within our own institution, and I would say one of the challenges, as Dr. Magee was saying, is education. So I think a lot of patients aren't aware yet. If you ask most patients, they know about mammography, they know about colonoscopy, but this is the new kid on the block. So this is relatively new. A lot of patients don't know about it, and so they need to be educated. The NLST investigators were very wise in that when they published the study in the New England Journal of Medicine showing this excellent survival benefit with screening, they collected data on the cost as well. So a couple years later, they published that data, and then CMS drew their attention, and so it is covered. And so that's another important thing to share, is patients don't have to pay for this out of pocket. Now there's the option, but most insurances cover it. So that's important. Challenges also include the institution that you're in. I think, in my opinion, the best programs for lung cancer screening have a central healthcare provider who is in charge of the program. And by that I mean not just overseeing the day-to-day operations and things, but actually doing the shared decision-making, doing the smoking cessation counseling, taking a referral, seeing the patient, discussing what lung cancer screening means, the risks, the benefits, counseling them, providing that feedback to the referring physician, ordering the CT scan, and then going through the process of following up on those results and acting on them if they need to be acted on. So I think, in my opinion, that that's the best. That's not going to work everywhere, but I think this way you're less likely to miss nodules.
Yeah.
Okay, so it's safer. I think we all worry about this within our own programs and how many people are getting screened, and if there's a lot of different doctors and providers ordering it, are we going to miss some? So who's going to follow up on it? So you have a central person actually following up on all those scans. I think that's the best way to do it. It's difficult. I've reached out to primary care doctors, and they have time constraints. They see patients. You know, we see patients and we take care of one or two problems. They see patients long term. There's a lot of things that they need to take care of besides lung cancer screening, and the challenge is different from mammography and colonoscopy, where there's now a shared decision-making component, and that takes time, and there are very strict criteria for how that needs to be done. It's important. It's important to explain to patients what the risks are, what the potential benefits are, because a lot of times patients will have a CT scan, a nodule will be found, and they'll have anxiety, and most people think that all lung nodules are cancer, which is not true.
Right.
And so it's important to have those conversations, but it takes time to do these things. And so the primary care physicians are feeling the pressure to take care of lung cancer screening, doing all these other, managing all the other comorbidities and other medical problems. And so what we've done at our institution is we've offloaded that, and we've created our own referral stream so that we'll do the shared decision making. We'll see those patients, and that can be one of the challenges in setting up your program.
Right. So you've seen that a centralized model rather than a decentralized model is working best, at least at your center, and in terms of coordinating how the patient flow goes and making sure that there aren't any gaps in follow-up.
Right.
We've seen the same thing. We do have a single person that runs our lung nodule clinic and spearheads that, but I had a question for you, because I get this question all the time and I don't always know what the right thing to say is. How do you manage those other things that get picked up? So you're running this program, you've got patients coming through, nodules get managed. What do you do when an aortic aneurysm comes up, or all these other findings, ectopic calcium somewhere? What do you do with that?
That's important. It's very important to pay attention to those, and I do believe there are studies out there that have looked at these are the side benefits of screening, is you're gonna find other things. You may find other tumors in other parts of the body. And so it's very important, is with not just screening, but even our own lung cancer patients. We may find other things on their scans, or trauma patients are a great example. They get CT scans and we find a whole host of things, and we get a lot of lung nodules from that service. But it's important that you document those in your note and refer them to the appropriate person. You can't just push those aside. You have to address them.
Probably another reason why centralization might make it a little easier.
It would.
It does, yeah. So, Dr. Magee, I'm going to turn back to you. So, one of the things that I've noticed is that some healthcare policy experts have said, well, these resources that you're talking about for CT scan screening for patients at risk of lung cancer, and Dr. Brown just talked about the cost effectiveness, but it's still expensive, and they say these resources would be better used at smoking cessation. We ought to take these resources and instead of pouring them into lung cancer screening programs, redouble our efforts at smoking cessation. What are your thoughts about that?
Well, I don't think you can separate one from the other. It's not one or the other. I think they're actually quite complementary. And one of the things that Dr. Brown mentioned in her shared decision making was talking about smoking cessation. We know that there are only two things that can impact lung cancer mortality, and that's low-dose CT screening and smoking cessation. And they're both important. Low-dose CT screening can pick up a cancer when it's much more treatable, but it doesn't prevent cancer. It identifies it at an early stage when it's treatable. The only thing that actually can prevent cancer is smoking cessation. And that's why I think it's a very important part of that shared decision-making process that we emphasize that in our discussions with patients. And we also emphasize in that shared decision-making process that it's not just a single test that they're coming in for. It is a series of tests. Oftentimes it requires some follow-up. And as a result of that, it also gives us an opportunity to help counsel those patients about smoking cessation opportunities and follow up on their effectiveness and emphasize them in their follow-up visits. I think smoking cessation obviously is a challenge. We've been dealing with it for several decades now. Health policy has definitely impacted it. As I mentioned before, the number of patients eligible to be screened is going down, but due to effective smoking cessation policy, I think there's no question that decreasing the smoking in public places has impacted the number of smokers. I think it's important to mention whenever we're talking about smoking cessation and prevention, to mention what I think is a major problem right now in our young people, and that is what has been recently declared as an epidemic in vaping or e-cigarette use. I think we're quite possibly developing a new generation of future smokers. It's been shown that vaping actually, rather than decreasing the likelihood that a young person will smoke cigarettes, it increases that likelihood. We don't know what all the chemical effects are aside from nicotine, but we do know that the nicotine is included in a lot of the e-cigarettes and the vaping. We know, just like back in the 60s when it was claimed that there was not much detrimental effects to nicotine, a lot of the same myths are being propagated right now about vaping and e-cigarette use. And I think it's important for us to pay attention to that right now, educate the parents and the young people about the risks, the unknown risks right now of vaping and e-cigarette use. Between 8 and 11% of high school students now are vaping.
Wow. Yeah, so probably the tip of the iceberg of a new public health problem that our next generation may be dealing with.
Right.
I'm going to change track a little bit, Dr. Blackmon, and I'm interested in your thoughts of, besides screening, early detection, what other big advances are going on in lung cancer?
Well, when you ask me that, it reminds me of a quote that I heard from Julian Molina, who's one of our medical oncologists, at a recent meeting. And he said that in the past, throughout his career as an oncologist who cares for patients with lung cancer, he used to go to ASCO and other medical oncology meetings to keep up with his friends, go have coffee, go eat dinner, learn about other diseases, but really lung cancer was a little bit dead, and there wasn't a whole lot going on besides a cisplatin doublet. I mean, that was about it for a long time. But in the past 4 or 5 years, he said that the #1 tumor that's being discussed at every meeting is lung cancer. And the driver mutations that we're seeing that drive therapy are changing the landscape of how our patients survive. I think we're going to see more cancer surgery being performed. We're going to see some of those unfortunate patients who don't get lung cancer screening coming for treatment with advanced tumors that might survive now twice as long as they did before. And then the early cancer patients who get surgery, perhaps even some of those patients are going to be offered immunotherapy to prevent subsequent cancers from forming or to protect them if they have multifocal lung cancer. So I'd say the landscape right now looks quite good for lung cancer patients, especially relative to how it has looked in the past 10 years. I think in general, if you have patients with a non-squamous lung cancer that have a driver, they probably need to be treated at a first stage when appropriate with some type of immunotherapy. Because when you compare those people to people who are treated with immunotherapy versus chemotherapy, they're always going to do better. And then when you look at people who don't have a driver, just to simplify the whole thing, you might want to do PD-L1 testing. If the PD-L1 testing is greater than 50%, then those people are typically going to be offered pembrolizumab, and then those patients who have a less than 50% will be getting alternative therapy. So that's sort of a 30,000-foot view of my opinion on immunotherapy, but I think essentially it's really exciting. I think our patients now are not hopeless. Even our metastatic patients now have hope. Some of the patients that I think I might not have stayed in touch with because they would have gone on to palliative care and not really survived, I'm now still friends with occasionally on Facebook. It's really nice to stay in touch with those people.
So, Dr. Brown, I'm going to give you the last word on that. Briefly, as we're wrapping up, what do you see the future is for how immunotherapy is impacting our care of patients with lung cancer?
Well, I think it's a really exciting time to be a thoracic surgeon and to be taking care of patients with lung cancer, because I think every time I open the New England Journal of Medicine, there's a new kid on the block in terms of a new agent, a new drug, and it's very exciting. I see our medical oncologists, as Dr. Blackmon mentioned, treating the metastatic patients, treating the later stage patients, and some of them are having very robust responses to these agents, such that they're living much longer than we would have expected. What they're trying to sort out right now, though, is how come some patients are having an excellent response? Sometimes up to 50% of patients are having this type of response, but others don't. And so that's the next step, is to figure out who's going to respond and who's not, and to then tailor that therapy appropriately. So we can learn from them because they are ahead of the curve in using these agents. I think it's a little early to tell in terms of how is it going to fit into the grand scheme of things for our patients with early stage lung cancer. There are surgery is still standard of care for early stage lung cancer, but there are trials going on right now that are comparing surgery alone versus immunotherapy first, followed by surgery. So it's going to be very exciting to see what the results of those studies are, to see if we can increase the survival even more than just doing surgery alone.
That's terrific. So you can see it's an exciting time in lung cancer therapy. We have a chance now with early detection to really change the survival curve for our patients, which has historically been an overall survival of 18%, which can really be inverted to a survival curve of over 80% in patients that have early detection. But you've heard our panelists also talk about advances in systemic therapy and immunotherapy and how it's impacting patients with all stages of lung cancer, including advanced lung cancer, and the opportunity to take some lung cancer patients and turn it into a chronic disease instead of a fatal disease. And so it's an exciting time for those of us that spend our careers caring for patients that are at risk of lung cancer or get lung cancer, our goal being to take more patients and help them be lung cancer survivors. Thank you.